Hello, I'm Rachel Ogilby, recent doctorate graduate from Kent State University, current living in Paris, France. This presentation is Restore, Improving Resilience and Reducing Burnout in Critical Care Nursing Staff. Burnout is a significant problem in nursing staff around the globe, and it's correlated with turnover, absenteeism, and poor patient outcomes. Even though burnout is a leading patient safety and quality concern, only 5% of organizations report being highly effective at addressing staff burnout. High rates of nursing turnover are largely due to stress in the workplace. This contributes to a reduction in quality care, and rates of nurse turnover are inversely related to quality metrics. This includes physical restraints and pressure injuries. Disruptions in workflow, continuity of care, and variability between clinicians because of nurse turnover compound concerns of patient safety. The purpose of this doctorate project was to determine if a 4-hour resilience class that focused on emotional intelligence, self-care, resiliency, and art therapy decreased burnout symptoms in critical care nursing staff. The study was quasi-experimental with a pre-test, post-test design and a non-equivalent control group. Participants were recruited from critical care units at a large level 1 trauma hospital in Northeast Ohio. Inclusion criteria consisted of critical care nursing staff that worked part or full-time in the cardiac intensive care unit, the cardiac step-down unit, or the burn intensive care unit, and could communicate in English. Demographics collected included job position, age, gender, years in current position, years in critical care, plans to leave the organization or healthcare in the next 5 years, and the highest educational level. Convenience sample strategy was used. The goal was for 100 staff to participate, and 90 staff participated. Critical care nursing staff registered for Restore themselves via sign-up or by their nurse manager, and they were paid at their current wage for their time. This time was either added to their scheduled bedside hours or were included in their typical weekly hours at nurse manager discretion. Paid time away from the bedside for the training was approved by the Director of Nursing. Per direction of this Director of Nursing, these staff members were required to participate in the training, although they were not required to take part in the study, so they did not need to complete the burnout and demographic questionnaires or the evaluations. The training was given over one 4-hour period, and it was offered 6 times in order to fit with as many nurses' schedules as possible. It was offered from 11 a.m. to 3 p.m. in a room within the hospital. The class took place away from the nursing units to alleviate fears of being pulled into staffing and to help create a reduced stress work environment. The Restore included presentations on those 4 items: emotional intelligence, resiliency, self-care, and art therapy. Each of those presentations lasted between 30 and 60 minutes for a total of almost 3.5 hours of presented material. The remaining 30 to 40 minutes were used for introduction and conclusion of the event. Participants were given beverages and lunch during training. This training was IRB approved, and staff had the option to receive 100 points for participating in the training, and these points can be used towards health insurance discounts or a health savings account. The Maslach Burnout Inventory is the most widely used instrument to measure burnout symptoms. This is a 22-item 0 to 6 Likert style questionnaire. The questionnaire results to analyze them are typically compare the MBI scores. So 3 scales are measured in this, and that includes emotional exhaustion, depersonalization, and personal accomplishment, and those 3 scales are what make up burnout. This survey was provided at the beginning of training and again 6 weeks after training. The surveys were given in person pre-training and then via online distribution post-training. The survey was also given to the control group. The control group consisted of 50 nursing staff members. This was the medicine step-down unit. All control group surveys were given via paper form. 12 participants in the control group completed this survey. All staff were also given the same post-survey 6 weeks later, and 6 participants completed that survey. Incentive was provided to all participants who completed the pre-survey and the post-survey from both the control and the intervention group. They were entered into a drawing for one of 6 $50 gift cards. Winners were contacted via email and given the gift card from their manager. Findings. A paired t-test was used to evaluate if participants' burnout symptoms decreased after resilience training. There was not sufficient power to detect a significant difference in the burnout symptoms pre- and post-intervention apart from one question, which was an unexpected outcome. This was the increase in depersonalization symptoms from the pre to the post-intervention group, and this might be explained by the study taking place during COVID and many staffing challenges. Other findings showed that the critical care nursing staff had worse burnout symptoms than those of the general population of other workers in human services professions. You can see this by the first 3 charts under findings. Each pre- and post group in the intervention and control group all had worse emotional exhaustion scores than the average population, and all had worse or equivalent scores in personal accomplishment. Additionally, nursing staff who planned to leave the organization in the next 5 years showed emotional exhaustion mean scores that were significantly higher than those who do not plan to leave. Participants were asked to circle their top 3 stressors and were given the listed options you can see in the next chart. Many participants circled more than 3. The top 3 stressors for participants were lack of staffing, that was 67% of respondents, lack of supplies or resources, 60%, and fatigue or irritability, which was 41%. High patient acuity was the 4th stressor at 34%. Of the 14 participants who circled other and wrote a comment, which was 17%, the overwhelming theme of comments focused on support from management, with 6 of 14 comments focusing on that. 3 comments mentioned coworkers and another 3 identified floating as a stressor. Age made a statistically significant difference in depersonalization and personal accomplishment scores. Participants who were ages 25 to 34 showed a significantly higher mean score of depersonalization compared to those who were 45 and older. Additionally, those who were 35 to 44 showed a significantly lower personal accomplishment score when compared to those 55 and older. Conclusions. Critical care nursing staff at this organization have worse burnout symptoms than those of the general population. Staff who plan to leave the organization are more emotionally exhausted than those who plan to stay. And we found that nursing staff value resiliency training. All attendees of Restore were given an optional evaluation to complete at the end. 83 of 90 participants, so 92%, completed the evaluation. Participants were asked the following questions. How well did Restore meet your needs? How likely would you be to recommend the educational material you learned today to a colleague? And how will this program affect your practice? 77% of participants stated that Restore exceeded or fully met their needs. 87% said they'd be very likely or somewhat likely to recommend the training to a colleague. Speakers were given high evaluations on teaching effectiveness across the board. So the impact on practice. Although the study was unable to prove that resiliency training reduced burnout symptoms in critical care nursing staff, the Maslach Burnout Inventory scores collected provide an opportunity for this organization to acknowledge and respond to burnout scores, especially as these scores were higher than those of the general population. Statistically significant areas of interest include the burnout characteristics of certain age groups, and the organization can choose to focus burnout reduction strategies on this age group. The cost of implementing burnout reduction strategies is justified. We know this from the literature, and as well as nursing staff who plan to leave the organization in the next 5 years are more emotionally exhausted than those who plan to stay. The organization can use this information as proof that burnout has the potential to impact the turnover of their staff and then greatly impact cost. This study confirms and validates other studies which prove the same phenomenon. Nurses are facing burnout symptoms, they're at risk for leaving organizations and nursing altogether, and they value training on management of burnout symptoms and learning resilient strategies. Hospitals, organizations, and nursing schools can use this knowledge to incorporate resilience training and have transparent discussions about the risk of burnout. Training and interventions related to emotional exhaustion, depersonalization, and personal accomplishment may help mitigate the effects of burnout and help prepare nursing staff better for their chosen careers. Early resilience training has the potential to impact the nursing profession positively and should be considered by nursing education leaders in curriculum planning. The clinical significance of Restore cannot be fully realized without additional measurements of nurse turnover, patient outcomes, and staff satisfaction. However, the potential outcomes as shown by previous studies include an improvement in patient satisfaction, nurse job satisfaction, a reduction in nurse turnover and therefore cost savings, an improvement in patient outcomes. The potential impact on everyday life of the critical care nurse is an improvement in team morale and an overall uplifted spirit for the unit and hospital culture. These impacts, though very difficult to measure, provide a strong argument in favor of implementing an annual 4-hour course with the goal to improve resiliency and decrease burnout symptoms. Even when unable to prove statistical significance in the reduction of burnout symptoms, these anticipated changes should be contemplated when considering current mandatory programs for staff. The potential positive impact of resiliency training should also be closely considered when creating healthcare policy at the local, state, and federal level. Finally, the systematic investigation of the effects of resiliency training on critical care staff should be considered. Restore and resilience training have been shown throughout the literature to make positive impacts on healthcare workers and patients. Through clinical inquiry, it can be observed that even without meticulously analyzing the data, resilience training is a clinically relevant intervention to improve the health of critical care nursing staff. Thank you so much for your time and attention. For questions or further discussion, please do not hesitate to reach me, and you can do that by email at rcogleby@gmail.com. Thanks so much and have a great rest of your day.